The first video this week is discussing pharmaceuticals in politics and policy, Medicare Part D. This slide discusses the eligibility for Part D. Of course, you have to be 65 years old or have a disability that is qualifying. End-stage renal disease will qualify somebody for Medicare and Part D, and ALS, also known as Lou Gehrig's disease. You have to be enrolled in either Part A or Part B to be eligible for Part D. There is a formulary that has all the covered drugs, and plans can change their formularies, but they have to give notice before they do that so that you can, or the beneficiary can go to their physician and get the drug changed. Sometimes the physician will be able to write an exception because this med is the only one that works, for instance. Sometimes when there's like multiple blood pressure meds, only one really is effective. So there are ways to get coverage even if it is taken off of a formulary. Most, Part D plans use tiered formularies where they group into different tiers based on cost. So that would include tier 1 would be generic or very low cost medications, where the higher tiers will have brand names or higher cost sharing drugs. Determination of coverage, if a medication is not on the formulary, they have to review the request, the physician submits evidence, and provide the provider with a decision. And then many plans use drug utilization management tools like prior authorization, step therapy, quantity limits to control costs and ensure appropriate use of medication. Step therapy would be like you can't jump to like Nexium or Protonix. You have to try Pepcid first if you have a lot of heartburn. You don't jump to the most expensive drug. You have to step by step prove that you need the most expensive drug. Cost sharing, when we talk about cost sharing, that means that there's a portion of the costs of covered medications you are responsible for paying as the beneficiary, in addition to your monthly premium. There are several types. Some Part D plans have an annual deductible, which you pay out of pocket and before the plan starts paying everything. And then coinsurance or co-payments. After you meet your deductible, you pay a percentage of the cost or a fixed amount for each prescription while the plan pays the rest. The coverage gap or the donut hole. In the past, you would hear people talk about the donut hole, and that is when beneficiaries had to pay a higher percentage of their drug costs because they met a certain coverage limitation. That was removed in 2020. I included here because it was a political thing. It was a change in policy based on a lot of lobbying. I don't know what's going to happen in the future with Medicare Part D, so I am going on what was known about what Medicare Part D was before the current changes are being made. Out-of-pocket expenses are just what they say. It's what you pay out of pocket. And when you're taking care of somebody who's going on Medicare and considering Part D, it's really important to have them review those cost-sharing differences in the different plans before they choose, because the amount they have to pay is going to vary depending on those cost-sharing indications. The coverage gap, I talked about the donut holes. I'm not going to go into it. It's here for you to read, but it was a huge deal for individuals on Medicare. That policy changed, but I'm not sure how it will be in the future. There are enrollment trends. There are periods for Medicare Part D, just like all the other parts. There's an initial enrollment opportunity when you first become eligible for Medicare, when you turn 65 or you have a eligible disability. That IEP lasts for 7 months, beginning 3 months before the month of your 65th birthday, including your birthday months, and ending 3 months after your birthday. And then there's an annual enrollment period. Like open enrollment just says that people who have coverage from their work have open enrollment. Medicare has open enrollment, and that is every year from October 15th to December 7th. That's when you can make changes to your plans, including Part D. There are special enrollment periods. If there's a qualifying event during your year in Medicare, such as you move somewhere and you can't use your Part D plan because you're somewhere new and there's different coverages. And then Medicare Advantage open enrollment period, that's the managed care option for Medicare. It's January 1st to March 31st each year. And this can be very confusing for some folks. It would be nice if everything was aligned. Okay, there are different types of plans. I'm not going to just read them here, but I'm going to say there are different types of plans, and individuals need to figure out which one works best for those. Standalone Advantage prescription plans. Some employers or unions have plans for their retirees, which has Medicare D coverage, might be better than Medicare Part D coverage. If that's the case, people wouldn't choose Medicare Part D. And then there are special needs plans for people with specific diseases. It's really important to compare when choosing plans. And when I was practicing, would always have my patients be very cautious when going to the Medicare Advantage, the managed plan, because even though there is medications rolled into that, it's still there are limitations that a lot, especially the current generation of older people, cannot tolerate related to that. Like their physician, they might have to have a new physician because their physician might be not in that Medicare Advantage plan. So even though it does have Part D, there are limitations. And here's some other things that I would have you read on the PDF. I'm not going to go into the granular information about Part D. It's here for you to review. But I will say that it's really important that when you're talking to a patient, that they take care. There was a lot done in the last few years to lower the cost and limit how much pharmacies can charge for their medications, but I'm not sure how that will continue. Like any plan, Medicare Part D does have challenges. And costs and affordability, making sure prescription drugs are affordable, especially for older people on a fixed income. Sometimes complexity and choice overload. If there's so many plan options, it stresses older people out when they're trying to choose which plan, and they're getting bombarded with different plans. So sometimes it's nice for them to have an expert guide them through that. And like senior services in their county often will have folks that they can send people to help with that. Formulary restrictions, just like with any insurance plan. That coverage gap and tiered pricing, which they were trying to get rid of the coverage gaps, but the tiered pricing can be challenging to understand. There's no negotiating power. Excuse me. Part D doesn't have the authority to negotiate drug prices, so if the it's not on the president or Congress's agenda to push for those negotiations, then they don't happen. Fraud and abuse, like any program, Medicare Part D is vulnerable to fraud. And there have been instances when pharmacies overcharge people for medications or billed for services not rendered, which increased costs to all and questions the integrity of the program, and which is probably why there's such a push right now to look at programs to see if there is fraud and abuse. And then access and disparities. For some groups, getting access to affordable medications is difficult, especially in rural or underserved areas. It can make health inequities more pronounced for these individuals. Well, when I wrote this future outlook, it was last fall, so I'm not sure how prescient, how things will move forward, but we do know that drug costs are going to increase. There is a interest in value-based pricing for prescription drugs, and that links the price of the med to its effectiveness in treating the condition. So one of the things they were doing was looking at trying to incorporate some sort of value-based pricing. Benefit design changes. They're looking to for changes to meet the needs of beneficiaries better, and looking at its cost-sharing structures. And just, I think one of the things that a lot of policymakers are looking at is trying to simplify Medicare, including Part D. And then, as with anything, telemedicine and digital health will have a impact, because these are expected to grow, and it may impact how medications are prescribed and managed. So Part D may need to adapt to that. Better integrations with other programs. Medicare D is like kind of on its own, but they're looking at maybe Medicare Advantage plans or Medicaid also having coordination with Part D to better manage prescription drug costs for all. And if there are new regulations passed, it could impact Part D. And policymakers are considering reforms to look at pricing, yes, but also access to care and the sustainability of the Part D program. And then there needs to be a better focus on prevention and chronic disease management. When I was an advanced practice nurse, I used to say that, they will pay for open heart surgery, but they wouldn't pay for someone to put the elderly person's pills in med boxes so that they would take their medications and their congestive heart failure or COPD or whatever was impacting them wouldn't get worse because they would be managing their medications effectively. So that's just a short look at Medicare Part D. Hopefully the program will be maintained. Hopefully it will be improved, and things will work out the best for our vulnerable, older, and disabled populations.